Hi guys, my name is Michelle Beagle. I'm one of the adjunct faculty here at Spring Arbor University for the Nurse Practitioner program. It's a pleasure to have you here in class. I am going to be giving you a lecture today on diabetes, so let's get started. So let me share my screen with you so that you can see the PowerPoint that I have ready. Okay, so again, today we're going to be talking about diabetes, the pathophysiology, the management, and the goals. Prior to talking about what our management and goals are going to be, I think it's important that we review the pathophysiology of the disease. As you are well aware, there are two different types of diabetes. There is both type 1, where an individual does not produce insulin because the beta cells have been destroyed, typically because of some type of an autoimmune disorder. And then there's type 2, in which there is some insulin production. Sometimes the beta cells can peter out over time, but there is definitely some insulin resistance, and typically that's adult onset diabetes. So I want to take just a minute and have you watch a video, and it's about 6 minutes long, but it does do a pretty good, succinct, in-depth review of the pathophysiology of the disease.
Hello, in this video we're going to talk about diabetes pathophysiology. This is an overview, specifically focusing on diabetes type 2. Diabetes type 2 is a problem where the hormone insulin, which is normally secreted by the pancreas, does not actually work properly. The pancreas is an organ sitting behind the stomach and secretes many things for digestion, but also it produces and secretes hormones which are very important for metabolism. One of these hormones is insulin, which is produced in response to high blood glucose. An example is after we eat, glucose enters our blood, and then here it will stimulate the pancreas to produce insulin. Before continuing on with the pathophysiology of diabetes, we actually need to understand what normally happens and how insulin works in a normal scenario. So again, here is the circulation, here is the liver, and here is the pancreas. The pancreas is the organ that produces insulin, and here is the adipose tissue, fat basically, and here is the muscle cells, skeletal muscles. And on these organs, on these cells of these organs, there are receptors for insulin. So again, high blood glucose will stimulate insulin production and insulin release from the pancreas. The insulin will then target these different organs by binding onto insulin receptors or insulin sensitive proteins, with the sole purpose of decreasing blood glucose levels. The binding of insulin to its receptor or protein triggers a cascade of events within a cell, leading to the increased uptake of glucose from circulation into This is done, for example, by producing more glucose channels or transporters on the surface of cells, allowing glucose to move from the blood into the cells of the organs. Insulin also promotes glucose storage. In the liver, insulin stimulates glycolysis and glycogenesis to store glucose as glycogen. Insulin also stimulates glucose to be stored as fat, which will be subsequently transported to adipose tissue. So going back to our first diagram, remember, high blood glucose stimulates insulin release. In type 2 diabetes, there is insulin resistance, which means that the receptors insulin works on usually does not actually work properly or as effectively. And so insulin essentially does not work properly on liver, adipose tissue, and skeletal muscle. And as a result, there will be high blood glucose levels for longer periods of time. Now, insulin resistance occurs because of a variety of factors, including genetics, family predisposition, bad eating habits, and also obesity. So, because of insulin resistance, glucose cannot be taken up by all these different organs, and so you have high blood glucose. Because there is high blood glucose, the pancreas is told to secrete more insulin, despite not changing the fact that insulin sensitivity is present. With persistent high blood glucose, the glucose will travel to the kidneys and be secreted out. This is called glucoseuria. Glucoseuria will result in osmotic diuresis. What does that mean? Well, glucose will essentially drag water with it because it is a solute. And so the person will start peeing more, polyuria. With constant polyuria, you get loss of water and you get loss of electrolytes. The loss of water and the loss of electrolyte leads to two main things. One, dehydration because of the loss of water, and two, hyperosmolar state. Hyperosmolar state is a medical emergency, which will not be really discussed here. The dehydration will stimulate the brain to drink more water, so we get polydipsia. Insulin resistance can actually lead to polyphagia, which means the urge to eat more or the feeling of hunger. And how does this happen? Well, if there is high blood glucose and it doesn't go into the tissues that need it, the organ will say, hey, I'm not receiving enough food, feed me. And so you get polyphagia. Prolonged dehydration in serious cases can lead to renal failure because of the decrease of blood flow going to the kidneys. Remember that insulin has many functions in the liver, and because of insulin resistance, glucose is not stored properly. Instead, you can get the opposite. You can get the liver actually releasing more glucose in the attempt to supply the organs that need it. It is important to know that with prolonged insulin resistance, eventually the cells in the pancreas that produces insulin, called the beta cells, these beta cells will atrophy because the body is not responding to the insulin properly. And so this will further cause problems, and the person who has diabetes will eventually need to be on insulin injections to compensate.
Okay, so now that we remember and can more adequately discuss what the pathophysiology is of specifically type 2 diabetes, I'd like to get into what the diagnostic criteria is for it. So if you have a patient that comes into your office, you'll have a better understanding of how to diagnose them with diabetes either for the first time or confirm perhaps that they do have diabetes or explain it to them. So there are several different ways that you can come about this diagnosis, and I put them into these three columns. The most common by far is typically going to be with the use of a hemoglobin A1C, which is in this far left column. In order to give somebody the label diabetic, you have to have a hemoglobin A1C of 6.5% or greater. That pre-diabetic, or the more commonly used vernacular, is impaired fasting glucose, is between 5.7 and 6.4, and then anything less than 5.7 is considered normal. Another really common way of diagnosing diabetes is with this fasting blood sugar. So fasting plasma glucose, fasting blood sugar, and pre-diabetic or impaired fasting glucose is going to be between 100 and 125. But once you cross over that 126 mark and above, then we can label them as a diabetic, typically with two separate lab draws on different days. So oftentimes what you'll find happens is that you have somebody who has an elevated blood sugar, and then we follow up with that perhaps with another fasting blood sugar or with a hemoglobin A1C in order to give them the diagnosis. Much less commonly, you'll see an oral glucose tolerance test in the right column. It is a viable way of diagnosing diabetes. Typically, you'll see that a little bit more in the endocrinology groups, but certainly not wrong to do that if you choose to. So then I want to take a quick peek at this slide called the ominous octet. This is the 8 core defects of a type 2 diabetic specifically. In the pathophysiology video that you just watched, we saw these different 8 core defects fleshed out in more detail, but these are the things that are wrong with an individual when they have type 2 diabetes. So we know that they do not secrete insulin the way that a non-diabetic does. We also know that there's some insulin insensitivity going on in the body. We do know that they overproduce glucagon and glucose, both from the pancreas and from the liver. We know that there is decreased what we call incretin effect, which will come up later. We know that there's decreased glucose uptake in the muscles. We know that the kidneys aren't doing their job and they're increasing the amount of glucose that they're bringing back into the body rather than releasing it as urine. We know that there's reduced glucose uptake in the fat tissues, and so it tends to circulate in the blood more often. And we know that there's some neurotransmitter dysfunction in the way that it's regulating the blood sugar. So again, 8 different causes that make up the 8 core defects or the ominous octet for diabetes. So other than diabetes, there is something called metabolic syndrome that is relatively common in the United States. We know that 22% of Americans suffer from metabolic syndrome. And this is a bit of a precursor to diabetes. It is not quite the same as impaired fasting glucose, because you can see that in order to diagnose you with metabolic syndrome, you only need 3 of the things that are listed here, fasting glucose over 100 being one of those. But you could have one of the other 4 components, 3 of the other 4 components, and still be considered metabolic syndrome. So what we know about metabolic syndrome is that it increases your risk of heart disease by 2 to 3-fold compared to somebody who does not have it. So these are the people that you really want to tackle and treat aggressively with lifestyle management and possibly medications, because they are at increased risk for poor outcomes, as well as significantly increased risk for progressing on to type 2 diabetes. So off to the left, you can see that some individuals are affected more predominantly than others. It does seem that men, at least slightly, are affected at a higher rate than women. And then off to the right, you can see that the non-white populations typically are affected more predominantly than the white populations. These are hyperlipidemia derangements. These are hypertensive individuals. These are individuals who have central obesity, specifically with increased waist circumferences, and then also have this impaired fasting glucose of greater than 100. So if we have somebody with either metabolic syndrome or we have somebody with impaired fasting glucose, what can we do when they come into our offices to help prevent them from progressing on to overt type 2 diabetes? So there are several different things. The first and foremost being lifestyle modifications. As you mentioned in the video, typically these individuals are ones that are already obese. They do have some central adiposity around the waist with increased waist circumferences. So we really need to be encouraging our patients to lose weight. There was a trial that occurred that put individuals in a couple of different arms in the study. One of the arms included weight loss, and what they recommended was about a 7% body weight reduction, which when you think about an individual that is 200 pounds, that's not really a significant amount of weight, about 14 pounds. And even as we get the weight goes above the 200 mark, that still is not a really significant amount of weight. So even with a 7% weight reduction, what we find is that it decreased the propensity of progressing on to type 2 diabetes by 58%. So really encouraging your patients to follow those CDC guidelines of 150 minutes of moderate intensity exercise weekly, and really focusing on a highly plant-based, healthy, balanced diet. The next bullet down talks about lifestyle interventions and then adding in medication. And in that same study that I referenced above, we found that in the arm of the individuals that we put on medications to lower their weight, we found that there was also a decreased propensity to progress on to type 2 diabetes. One example said that it reduced the progression to diabetes by about 80% over the course of 2 to 3 years. These are a list of just a couple of the medications that we can use for that. I do want to draw your attention to the liraglutide at 3 milligrams. Not at this dose, but at a smaller dose. The name brand of that is actually called Victoza. It is a diabetic medication. It's in a class called a GLP-1, which we will talk about here in the future. But I want you to start thinking in your mind how we could leverage medications like that to not only manage their weight, but in these pre-diabetic patients to also potentially manage their blood sugars as well and reduce their risk concomitantly. In the last bullet, you can see that there are some medications specific to individuals with impaired fasting glucose. Now, there isn't anything that at least I'm aware of that's branded specifically for impaired fasting glucose, but we can take some of the diabetic medications that we use and reduce their risk of progressing onto diabetes by about 30%. Typically, you'll see this in the use of metformin. It will help them to lose weight, which is really important. It is not a weight loss medication, but it is one of the favorable side effects of the medication, as well as help to reduce their risk of progressing onto type 2 diabetes and reduce their risk of heart disease, which we'll talk about in the future here. So once you've diagnosed a patient with diabetes, what is it that you're actually looking to do? What are your goals for management? When they come back to you, how do you know that you were successful? What benchmarks are you looking for to reach? So in that left column, what you're going to see is that most of the individuals really were relying on about that 7% mark is really what we're looking towards as far as a goal for the hemoglobin A1C. Now, some individuals, we can tighten up the goal, and some it's recommended that we do. Women who are pregnant, we do actually recommend that you decrease your goal for your hemoglobin A1C less than 6.5% because we do know that infants who are born of diabetic mothers tend to be much larger birth weights and can also have risk of premature delivery. And then also less than 6.5% treated only with lifestyle and metformin-like drugs. So if you are not on insulin, if you are mostly diet controlled, it really is a good idea because they can probably tolerate less than 6.5%. And then conversely, we oftentimes will raise that level of hemoglobin A1C goal in individuals who either A, are elderly and their lifespan is lower because we know that uncontrolled diabetes carries risk over time. So uncontrolled diabetes or elevated hemoglobin A1Cs in a, say, 90-year-old is less risky for microvascular and macrovascular disease because their life expectancy is shorter. If they haven't developed it at that point, they will probably die of other causes before they die of heart disease because of their diabetes. So we'll oftentimes raise that up. Also, there's other comorbidities that put them at bigger risk for potential hypoglycemia. If we really drive that blood sugar lower and try to work towards a tighter glycemic control, then we'll oftentimes back off of that. Chronic kidney disease, sometimes because of the medications and sometimes just because we need a little bit of relief with the kidneys, so we'll back off of some of the tight glycemic control in those individuals. So in the middle here, particularly with your type 1 diabetics, you will be having them get fasting blood sugars and postprandial, remember that's 2 hours after, blood sugars, and they'll often bring in a logbook with you to your office, and you'll start discussing what the goals are. So a goal for a fasting blood sugar is that it would be less than 130, and a goal for a postprandial blood sugar would generally be that it's less than 180. That will make a difference when you are titrating insulins on these type 1 diabetics. The far right diagram that I gave you really is just pointing towards the middle section, the middle column. It's just itemizing it out in a slightly different way if that appeals to you a bit better so that you can understand it. So the next few slides really are a series of slides that come to us from the American Academy of Clinical Endocrinologists. It is one of the major recommending bodies when it comes to diabetes, both type 1 and type 2. The other major recommending body is really the American Diabetes Association, or the ADA, so you'll see both of those, and we'll reference both of those throughout. The AACE, though, puts out these slides like this in a PDF format, or you can get them in a PowerPoint format if you prefer. But they do put these out generally once a year or every couple of years, updating their most current diabetes guidelines. I found them to be very helpful. When I first went into practice, I had a binder with me that I actually still have it in my desk. And when I would go to clinicals, I would add new things. This was always one of the things that I added into my binder. I jotted all sorts of little notes about the diabetic medications until I became more familiar with them, because there really are many diabetic medications out there available to us. So this first slide that we're going to take a look at really talks about, in a diabetic patient, what should we be doing to modify their other potential risk factors. So when an individual has diabetes, I think of them as kids' wood building blocks. And if the bottom building block is diabetes, and that carries its own risk of microvascular and macrovascular disease, then we have to start to consider that these other things like hyperlipidemia and hypertension are like another block on top of diabetes. So the risk for microvascular and macrovascular disease increases exponentially as we add the blocks on. Smoking would be another big one. Family history of cardiovascular disease would be another big one. So we start to add these blocks on. So the AAC tackles this and says that there are a few risk factors, dyslipidemia and hypertension being two of those that we know to be to put that individual at exponentially greater risk for poor outcomes. So they have adopted the guidelines that were originally established by the American Heart Association and the American College of Cardiology for the management of cholesterol. And what the ACC and the AHA did is they said that there are really four groups of individuals that they call 4 statin benefit groups that they really feel would benefit from lipid lowering medications, particularly statins, because they have the greatest level of evidence behind them. One of those 4 statin benefit groups are individuals with diabetes between the ages of 40 and 75. Interestingly, it does not reference what their cholesterol has to be in order to put them on a statin. So essentially what they're saying is any and all diabetics between the ages of 40 and 75 should be considered for, at minimum, a moderate intensity statin. There's a lot of controversy about that recommendation, but what they do know is that just the nature of having diabetes puts you at increased risk for heart attack. And so they are trying to do disease modifying behaviors by putting them on a moderate intensity statin. You can see in this slide, which is pretty complex, but you can see that depending on what your risk factors are, you could consider intensifying the statin intensity if your risk level goes up. So you can see over here, additional risk factors would be if you had a family history, like we talked about, smoking, chronic kidney disease, and then certainly an extreme risk individual would be somebody who's already been diagnosed with some type of cardiovascular disease. Off to the right then is hypertension. How should we manage high blood pressure in individuals who have diabetes? Well, what the recommendations really say is that our best medication is either the use of an ACE inhibitor or an angioreceptor blocker, or an ARB is what we call it, because it helps to protect the kidneys and it helps to decrease progression onto nephropathy. That's not to say that if you have an individual who's complex with several comorbidities that you should not consider, or that you should take them off of blood pressure medication that they're currently taking. If I have somebody who comes into my office with a heart attack and is already on a beta blocker because of a history of cardiovascular disease, such as the heart attack, I don't know that I would be really eager to take them off of the beta blocker and put them on an ACE or an ARB, because there's really convincing evidence that a beta blocker is protective in an individual with coronary artery disease and confirmed on CBD. So I would definitely leave them on the beta blocker. Now, if their blood pressure is controlled, that's wonderful. But if this diabetic in this circumstance is in my office and their blood pressure is not controlled, then certainly I am going to add in a second agent, and I would at that point consider doing an ACE or an ARB. The goal for blood pressure in a diabetic patient is also not the same as in a non-diabetic patient. The JNC8 and the AACE both do recommend that we keep tighter blood pressure control in a diabetic patient with a goal of less than 130/80. So this slide then really begins to discuss type 1 diabetes and what are we going to do with these type 1 diabetics and how are we going to be starting their insulin. So remember, type 1 diabetes really is going to be your old-fashioned name insulin-dependent diabetic. They don't produce insulin on their own. Their beta cells have been destroyed for a myriad of different reasons, and they do not produce. So just like you or I, who is a non-diabetic, would eat a carbohydrate, we get a surge of insulin because our pancreas kicks in the beta cells, and the beta cells release that systemically. They don't have that ability, so we need to give them that ability by replacing their insulin supply. We typically do that in two different ways. We typically do it with basal or long-acting insulin that doesn't really have a peak or a peak to it. It just stays in the system at steady state over 24 to sometimes even 40 hours. And then we also augment their insulin with mealtime coverage, and that can be done several different ways. But you'll see those two boxes there. Now, what most individuals will do is you can do a calculation, and TDD stands for total daily dose. You'll see that abbreviated quite often in the realm of diabetic management. So the total daily dose of insulin in that individual would be calculated as 0.1 to 0.2 units per kilogram, and you could calculate that out, and that could be your starting dose of insulin. Another really common way of doing it, just to make things a little bit more easy, is to start them on 10 units of insulin and then make 10 units of long-acting insulin and then make the adjustments from there. In my practice, a lot of times what I'll do, because I know, remember that fasting blood sugar goal is really less than 130. I will fudge that just a little bit to give them a little bit of wiggle room so that I'm not putting them into a hypoglycemic state. And I will have them start, say, at 10 units of long-acting insulin with instructions to increase that by 2 units every 3 days if their blood sugar remains over 150 fasting in the morning. And so they can slowly, incrementally increase that, knowing that 150 is probably still a little bit above where I want to be, but decreasing the risk of having them become hypoglycemic before I can see them back in the office. Then over on this side is the intensify or prandial control. So these are the individuals, I oftentimes will give them a sliding scale. So if they are checking their blood sugars before they eat, and if their blood sugar is, say, 200, I will have a correction sliding scale that will give them directions on how many units of rapid acting insulin they need to correct for that. There's also another way of doing that, in that you can give them a number of carbohydrates. Say if you have 15 grams of carbohydrates, then you are going to, in addition to the sliding scale, also give yourself, say, 2 units of insulin to help to correct that. These then are the different types of insulin that we have. There are several, but there are a few main categories that I really want you to be familiar with, and also that your boards are going to want you to be familiar with as well. So these rapid acting insulins up here, you'll see pretty commonly for your mealtime replacement insulins and your sliding scales. Probably most commonly Humalog and Novolog, but you'll see all of them. They just seem to be the most readily available. For the most part, they're what we call U100, which means that every 100 units is 1 ml of liquid. And their onset of action tends to be pretty quick. These are the ones that we take right before we eat or with our first bite of food, because it does start to work with anywhere short as 3 all the way up to 30 minutes after your dose. And it stays in the body for about 4 hours on average, and just in time to be ready for your next meal. Short-acting insulins, you won't see as many of these, but they are available out there. Regular, which used to be the most common one, its peak is a little bit longer, and it stays in the system for just a little bit longer as well. NPH is your intermediate acting, so it's not a meal replacement type of insulin, but it is an insulin that I don't want to call it basal, but we use it as an underlying basal sort of insulin, even though it does have a peak. That's the take home with the NPH. It has a peak, unlike some of the others that we're going to talk about in a second. So we know that if somebody brings in a logbook for you and you see that they take NPH, say in the morning, and by evening time, their nighttime blood sugar is suddenly trending upward, that may be because that NPH is beginning to wear off, and we need to consider BID dosing of NPH so that we're not getting that spike at the end of the day. So it's a matter of looking back at it and seeing what is the logbook telling us the problem time is for this individual. And then lastly, you'll see this long-acting insulins. Now, you'll see this both with type 1 and type 2 diabetics, but I think you'll see, as we start to talk about the medications that we use for diabetes for type 2 now, you'll see that we use less and less insulin than what we used to. But these long-acting insulins really have no peak. In fact, some of them are what we call ultra long-acting, and that's these two that are down here, Toujeo and Tresiba. They're ultra long acting, so typically they are in the body for 36 hours or even slightly more. So it is a true steady state that's happening, and even a little bit of overlap, so it just evens everything out without the peaks and the valleys that you can get with some of the shorter acting insulins. Just keep in mind that they all come at different concentrations. Toujeo and Tresiba you can see come in a U300 or a U200, so that means that U300 would mean that there are 300 units of insulin for every 1 ml. So if you have somebody who suddenly has, or maybe not suddenly, but has high insulin demand needs, and they maybe are injecting 60, 100, 120 units of long-acting insulin daily, they might be a good candidate for a U300 basal insulin because they're going to have less volume to inject. We know that they're going to have better absorption of that volume and less potential for leaking out into the extravascular or the adipose tissue, so you'll get better effect. So now here is really the AACE algorithm for managing a type 2 diabetic. So now we're going to be getting into the oral diabetic medications as well as the non-insulin injectable diabetic medications. This slide is understandably very busy. I don't expect you to understand what all of it means, but hopefully by the time that we finish this lecture, you'll have a greater understanding of what it is, what these abbreviations stand for, and then if you were able to print this off, really have a working knowledge of these medications and how you're going to begin to prescribe in your practices shortly. So I want to move forward to the next slide, and we're going to kind of work our way back and forth between 3 slides as we look at the different diabetic medications. So up here at the top is called a sulfonylurea. On the screen prior to it, it is this medication right here, this SU, is nicknamed sulfonylurea. Sulfonylureas actually increase insulin secretion by the pancreas, so they force those beta cells to release the insulin, because remember, that is not the problem in a type 2 diabetic. They have beta cells that are working, but they're either working ineffectively or there is insulin resistance that's going on, and the body isn't recognizing the insulin that's being released. You can see off to the right the generic and the brand names for these medicines. The advantage of these medications is that they are exceedingly inexpensive. So if you have an individual who has very poor prescription or no prescription coverage, these would be reasonable alternatives. But I want you to become familiar with this following slide. And again, I know it's quite detailed, but we'll go through these as we go. So in this slide, here is your sulfonylurea. So these are the advantages and disadvantages of each of the medications. And you can see with a sulfonylurea that the risk for hypoglycemia is moderate to severe. And it really does make sense that that's the case, as it is asking the beta cells to actually release insulin. So I think about it as sort of whipping the pancreas into action. And because it's doing that, you're getting a surge of insulin release, which insulin will then drive the blood sugar down and cause hypoglycemia or potential for it. So when we're looking at this chart, I often get asked, particularly from new providers or from students, how do I know what's safe to put together when we're talking about diabetes? Are these two medicines safe? If it's something that's going to cause hypoglycemia, it's not good practice generally to put two medications together that are both going to cause hypoglycemia. So we know that somebody who is taking a sulfonylurea is at increased risk for hypoglycemia. We definitely know that an individual who is taking insulin is at increased risk for hypoglycemia. So it naturally goes to say that if you have an individual who's on sulfonylurea, and you need to intensify their diabetic management and you make the decision to put them on insulin, it makes sense to say, we need to take the sulfonylurea off to put them on the insulin, or else our risk of hypoglycemia goes up significantly. So those two combinations definitely are not safe together. As far as weight, a sulfonylurea may cause weight gain, not a very favorable side effect in an individual who's probably already obese as a type 2 diabetic. It may put the renal function at risk, and it really doesn't have any favorable outcomes as far as heart disease. So that's really one of the things that I want you to become familiar with when you are reviewing the literature for diabetic management and medications. Not only what will it do to the hemoglobin A1C, but ultimately what does the outcomes data say about this medication? So when we talk about outcomes data, really what we're talking about is, does it reduce the person's risk of dying or major events over time? Typically with diabetes, we're talking about a stroke, a heart attack, macrovascular and microvascular disease. And what we see is that it really probably does not do that. It probably is either neutral in reducing risk or possibly harmful or increasing risk. The amount of hemoglobin A1C reduction, I added this to the bottom of it, is about 1 to 1.5%. So a decent bang for your buck when we're talking about how low we can get that hemoglobin A1C. So there's definitely a niche for sulfonylurea, but it's not one that I typically turn to first, because the outcome data really just doesn't support me doing that when there are some other medications that we're going to talk about that really do. So back to the slide, the next one on the list is a biguanide. That's a fancy name for metformin or glucophage. So this one works in a little bit different way. What this one does is it actually increases glucose production by the liver and increases the uptake of glucose. And that's written wrong. This should say it decreases glucose production by the liver and increases the uptake of glucose by the muscles. So the muscles snatch up the glucose where it can get to work as it should, and it decreases the amount of glucose that's being produced in the liver. So I like to tell my patients that it will not cause hypoglycemia, which you can see, here's metformin. It will not cause hypoglycemia, but the reason that it won't is because it's not lowering your blood sugar. It's preventing your blood sugar from coming too high. So if it's working on the liver and telling the liver, stop the glyconeogenesis, so you're not producing glucose, that the body doesn't need, then it's keeping the blood sugar low by not allowing extra sugar production from the liver. So when we talk about that scenario in that patient that you are considering intensifying therapy with and adding insulin per se, it would be okay to be on metformin and on insulin in most circumstances, because they aren't both going to be causing hypoglycemia. You can see that it does aid slightly in weight. I've seen it generally 5 to maybe 10 pounds at best, but it will help to kind of get that initial kickoff. There are some renal contraindications for metformin, particularly if your GFR is less than 30 at initiation. The newer guidelines do say that if your GFR, if you've already been on metformin and your GFR is, say, 30, you don't need to come off of metformin for that, as long as it remains stable and doesn't worsen. But a new initiation of the medication is not recommended with a low GFR. Biggest side effect tends to be GI symptoms, and I have had my share of patients who have come off of metformin because of GI symptoms. A couple of tricks to the trade for that: start low and go slow. when you start the medication. So I'll usually start it at about 500 milligrams once a day and slowly titrate up over the course of about a month to get them to a goal of, if they tolerate it, 2,000 milligrams daily. The other trick is, rather than ordering immediate release glucophage, there is an extended release version that does seem to be more tolerated with GI symptoms. So start them on 500 milligrams extended release and increase that up to a total of 2,000 milligrams over the course of about a month. Maybe a little bit cardiac neutral. There actually is some evidence that it might be slightly favorable for decreasing cardiovascular disease. And then as far as hemoglobin A1C drop, you can see that we'll get about a 1.5%. So overall, slightly better favorable outcomes. It decreases your insulin resistance, stops the production of glucose in the liver, and is generally pretty well tolerated. So when we talk about medications, this tends to be our first line medicine. It has been around for a very long time, and you can see right back here at this slide, metformin is listed right up at the top as far as potential for monotherapy as something to start early, and you'll see that in most clinical practices as well. Next line of medications is an exciting newer line. It's actually been around for a while now, but it's relatively new when we talk about diabetes management and medications. The way that it works is it increases the secretion of insulin in response to blood glucose. I don't know if you remember back to the very first video that we watched a few minutes ago, but there is actually this hormone that's circulating around that asks the beta cells to work more efficiently. So this GLP-1 is this circulating hormone, and it is stopped by another hormone called DPP-4, which you can see right below it. We'll get to those inhibitors. So it's activated and GLP-1 circulates, and then it's inactivated by DPP-4, and that will be important in a moment. The other ways that it works is it decreases glucagon secretion by the pancreas. It delays stomach emptying, so when we slow down the absorption in the stomach, we decrease the amount of sugar that is immediately absorbed. We slow that absorption of glucose into a more slow and controlled, so we don't get those postprandial spikes. So GLP-1s actually are quite good for individuals who have postprandial hyperglycemia. You may see that in a patient that comes to your office with their logbook, and their fasting blood sugars have been wonderful, but their hemoglobin A1C still remains above goal. It's probably because those postprandial blood sugars that maybe they aren't even checking are actually elevated. So something that would slow down the absorption of the glucose in the stomach may be a really good option for them to bring down those postprandial blood sugars and stop that after eating spike that we get. It also increases satiety, or that feeling of fullness, so that they are less full, and for that reason it's also pretty helpful in weight loss. These are injectable medicines, so they are not insulins. They are non-insulin injectable medications that most of the time you take weekly. There are a few of them, like Victoza, that might be taken daily. They do come in pre-filled syringes, much like you would see an insulin would come. Most of the ones that are weekly are a one-time use syringe, pre-filled pen, and then you toss that, and each week you get a different one. So let's move forward to this chart then. So we're right here, the GLP-1s, and you can see that it does not cause hypoglycemia. It actually helps to promote weight loss. And I want to go back for one moment. So we're still on the GLP-1. We're right here. And you can see, if you remember when we were talking about how to prevent type 2 diabetes, we talked about you may want to use medications for medical weight loss management. Liraglutide was one of those medications that was recommended. Now, when we're talking about liraglutide for the purpose of management to diabetes, that dose is lower than when we're talking about liraglutide for medical weight loss management. It's actually about 2 to 2.5 times higher the dose that we would give that individual than one who's a diabetic. But you could see how it would have favorable side effects that we may want to leverage. So if you have an obese individual who's diabetic, this might be something that you want to consider after you put them on metformin if their hemoglobin A1C is not within goal. You can see that There's a potential benefit in the renal department, particularly with these long-acting GLP-1s, so these weekly GLP-1s. Biggest side effect that I see for the reason to stop it is GI symptoms. I've had my fair share who've needed to come off of it. Some of the GLP-1s come in a lower dose, so one trick would be to start that lower dose. Some of them that are out on the market right now, I think about Ozempic, who has really marketed towards decreased GI side effects. So there are some things that you can do, but oftentimes it is a limit of the medication. Both metformin and GLP-1s, if you leave them on them for a couple of weeks, sometimes those symptoms will fall away and will tolerate them well. But particularly with GLP-1, sometimes they won't. And I have had, in a handful of times, needed to take individuals who just don't tolerate them off of it and change. One of the really exciting things about a GLP-1, though, is that there's some pretty good outcomes data in relation to it, that it actually does help to prevent macrovascular disease, so cardiovascular disease, heart attack, stroke, and death from heart attack as well. So I tend to put this right up there towards the top when I am starting to manage a type 2 diabetic. And talk for a minute when we're done with all the medications on kind of my strategy. What can we expect as far as hemoglobin A1C? About a 1 to 1.5% drop, so a pretty good bang for our buck. Back at this, here's those DPP-4 inhibitors. Remember, this is the green light, this is the red light. So this is what kicks into action, and a DPP-4 is what stops the GLP-1. So if we give you a DPP-4 inhibitor, we stopping GLP-1 essentially. So really they're working on the same system. They're really allowing GLP-1s to do their job just in slightly different ways. So I explain this to patients usually as their sister medications. They work sort of in the same system of the body in slightly different ways. But because now we're using the stop sign medication instead of the green light medicine, we don't get quite as big of a bang for our buck when it comes to the favorable outcomes data that we talked about with cardiovascular disease and heart attack and stroke. We also don't get quite as big a bang for our buck when we talk about hemoglobin A1C reduction. So why would we start somebody on this? Well, cost might be one of them. They tend to be a little bit less expensive than the GLP-1s. And also sometimes those injectable medicines like a GLP-1 are a pretty hard sell for some patients. So those are the ones that if I really feel strongly that a GLP-1 is the right thing to do, but they just will not agree to it, in my mind, that's often when I come back to a DPP-4 and recommend that. So these are medicines like Januvia, Tradjenta, Onglyza, Nsema, and you'll see those relatively infrequently, but you will see them occasionally. They mimic quite a bit of the GLP-1 because remember, they're sort of sister medications. They're weight neutral and hypoglycemic neutral, so they will not cause hypoglycemia. There is some dose adjustment that's due for the kidneys, but nothing that's significant, and really don't have any significant cardiovascular benefit as far as outcomes data. And here's where you see, compared to its sister counterpart of a 1 to 1.5% drop, we're really only getting a 0.5 to 1% drop. Back towards the bottom, a TZD, that is medications like Actos and Avandia. That really is the only true insulin sensitizer. So why don't we use this one more often? Let me come over here and show you. So here's the TZD. It actually can contribute to some weight gain, not a very favorable side effect. And then really the reason that they've somewhat fallen out of favor is because there were a couple studies, and actually one of the medications in this group were taken off of the active medications in the United States because there is an increased risk for individuals who are already at risk for CHF of developing overt CHF. It causes some fluid retention and weight gain. But there is a place if you have an otherwise healthy individual, usually young, without cardiovascular or CHF disease, and they don't tolerate metformin. This might be a reasonable alternative for them and something to try. And you see, you get a pretty good bang for your buck, 1 to 1.5% drop as far as hemoglobin A1C. Looking back then here at the bottom, this is a very exciting new class. This is also an oral medication. So this is an SGL2 inhibitor. So remember when we talked about the ominous octet at the beginning of the lecture, those 8 core defects that happen with diabetes. What we found with that is that the kidney, let me see if I can find that for you again. The kidney right here is one of the main 8 defects of diabetes. The kidney wants to hold on to the sugar that passes through, and rather than releasing it into the urine, it wants to take it back up and circulate it in the blood again, which is a problem for a diabetic. So what an SGLT2 does is it actually works in the kidney and promotes the release of the glucose from the urine. So this is the only medication that we have on the market at this time that actually functions in the kidney. So we're really getting all of the core 8 defects affected when we add in an SGLT2 inhibitor. Like I said, these are oral medications. They're relatively newer, so they're still relatively expensive, but there are a lot of coupons available. And because of the really favorable outcomes data in relation to these, most insurance companies are covering them at a higher tier, so it's less out-of-pocket cost to most patients. So these are medicines like Invokana, Jardiance, Farxiga, Steglatro, and they are found right here in this category. So the things to know about this is that it will increase your risk for urinary tract infections and potential mycotic infections of the vagina, or it can also cause yeast infections in men as well. But just logic would tell you why that is. If you're releasing extra glucose in your urine is now sweet. Bacteria and yeast and fungus love sweet environments, so it increases your risk for infections. So keep an eye out for that, and sometimes definitely reason to stop that. There's also some studies out there that say that it increases the risk and the need for amputation, limb amputation. We believe that that's in individuals who already have some microvascular and macrovascular disease. So you may want to think about those neuropathies that your patients will have. If they're pretty significant, you may want to find an alternative for that just because of that risk. They will help with weight reduction. Interestingly, they also help with blood pressure, so they can bring blood pressure down and are a great alternative for somebody who's just not quite there at goal as far as hypertension. If you add in an SGLT2 to get them better glycemic control, you could leverage that potential side effect and decrease their blood pressure into goal as well. They are thought to be relatively renal protective. They decrease the progression onto microalbuminuria, which is something that's important in screening for early diabetic nephropathy in these individuals. They don't seem to have any of the GI symptoms that the others have, and they have very good favorable outcomes data. So again, decreasing atherosclerotic cardiovascular disease, and really interesting decrease in heart failure hospitalizations. So much so that we're thinking that we're going to be coming up with an independent indication for an SGLT2. So independent of individuals who have diabetes, we think that there will be a recommendation to consider SGLT2 medicines for heart failure management as well. So if you have somebody who fits that category that's a diabetic, this is a great opportunity to use this medication. The other medicines that are listed, I'll let you kind of look through those on your own time, but these really are the big ones. But what I want to do is go back to the original slide and show you sort of my plan and how I set it up. If I have a new diabetic in my office, typically what I'll do is I'll start them on metformin. And remember, I talked about there's tolerability with GI side effects. So I'll start low and go slow. I'll typically start them on an extended release to maximize out to 2,000 milligrams over the course of a month or so, and then bring them back in at the 3-month follow-up and check their hemoglobin A1C again. If they need intensified therapy, my next thought is usually the GLP-1. Remember, these are your injectables like Victoza, Trulicity, Bydureon, those sorts of medications fall in, Ozempic, fall into that category, and they have good favorable outcomes data with cardiovascular disease. They are injectable, and I'll get a reduction of about 1.5% with my hemoglobin A1C. So that's usually what I'll do, and they cover almost all of the 8 core defects in that ominous octet. They come back in 3 months, If they still need some type of intensified or modified therapy, it's usually an SGLT2 if I can that I'll add on. So now what I've done is I've given them another oral medication with good favorable outcomes data. Again, remember, we're not just chasing the hemoglobin A1C, we want to reduce their risk over time. So good favorable outcomes data, it's an oral medication, and now I have pulled in that last piece of the ominous octet, which is the renal function. So I've now pulled that in, and I'm treating the core defect of increasing the glucose release in the urine. Beyond that, you can really play with some of these other medications and what works best for your patient. As long as you're understanding this chart here, which I think is exceedingly important and beneficial in your practice, as long as you're understanding this, you'll have a better understanding of the medications that you're prescribing and what to expect and how to leverage these potential side effects to work towards your advantage. So I wanted to share this slide with you because there is a guideline out there, at least for the state of Michigan. And if some of you are not in the state, then you may want to look in your own state for something like this. But what we know is that Michigan produces its MQIC practice guidelines, and I want to open those up for you. These are things that are generally required or highly recommended for the care of all diabetic patients as they come into a primary care office. So we really want to take a look at their cardiovascular risks, which we've been talking about this whole time, at least once a year. We want to know what their height and weight and BMI are. And then we want to do a comprehensive foot exam at least once annually. And you can see this is how often they're recommending that we do these things. They also recommend that they get a dilated eye exam by an ophthalmologist. So you want to instruct your patients that they need this annual diabetic eye exam, and that they need to inform their ophthalmologist that they are a diabetic, and they'll understand what type of exam they need to do for this fundoscopic exam. Lab tests, hemoglobin A1C, we do those about every 3 months. If you have a really controlled diabetic who's been controlled for some time, you could back that out to about every 6 months, but that would really be about the limit. Once a year, we really want to have them do a urine microalbumin, look for any signs of nephropathy. And then annually, we should be doing some other routine lab work, which you can see here. We should be considering in these individuals the possibility of starting them on a baby aspirin. We talked about the intensity of statins. We talked about management of hypertension. And so this really is just a different way to look at the information that we've covered throughout this lecture. And then over here, there's always a little reference as far as what your A1C goals are for most individuals. And this is a direct copy of what we can find in the ADA and the AACE guidelines. All right, so how are you going to take this into your practice? Well, there's a couple of ways. I talked about having a clipboard available to you, or I'm sorry, a 3-ring binder available to you and putting this in your binder. But if some of you don't like the cumbersomeness or don't have the room to be carrying something that clunky around, there are also guidelines that are available to you both electronically on your computer as well as on your phones and phone apps. So one of them is the AACE guidelines, which we've talked about through this whole lecture. Those are the screens that I've been toggling back and forth through. They generally get updated once a year with recommendations on first and second line medications and lifestyle management and all of that. This is available in an app form if you don't want to print out the PDF form. It's available online. This is what the app looks like so that you'll know what you're looking for on your phone. And it is very quick and pretty succinct and pretty easy to use as well. The other one then is the other recommending body that we talked about. So this is the American Diabetes Association. This is a little snapshot of what their app looks like. They're actually quite similar in nature as far as the recommendations and then any targets and things like that that we're looking for hemoglobin A1C goals and things like that. So I really hope that this has been helpful to you in understanding diabetes and the management of diabetes. I really encourage you to become familiar with the medications. That really is the name of the game when it comes to diabetes, and there are a lot of them and they do change quickly. But if you can understand what the classes of the medications are doing and what the function of them are in relation to that ominous octet, I think you'll be really successful in managing these patients safely and effectively. So let me know if you've got any questions. Let me know if I can be help to you whatsoever. I hope that you have success in the rest of your class and have a great night. Bye.